So I will just ask everybody to turn their videos and microphones off if you're not speaking, just so that we can avoid feedback on the call. We've got people joining now. Brilliant. Hi everyone, welcome to Disability Innovation Live for Clubfoot Time to Act. Really appreciate you joining today. I know we've got a lot of people from around the world, so welcome. We're going to wait 1 minute and then we are going to get started. Got more people joining. Hello, hello. Right, let's fire away then. Welcome everyone. It's lovely to have you here, as I said. We have got an action-packed day. We've got an hour and 15 minutes to talk about the issue of Clubfoot, its associated assistive technologies, and how we can change the world for children and adults with Clubfoot. We've got a whole host of different people joining us today, but before we do that, a little bit of housekeeping. We've got closed captions today, and they are enabled. You can start them by using the navigation bar at the bottom. This session is being recorded, and there will be an open Q&A. So the agenda for today is that we will have brief introductions, 3 presentations, and then we'll have a panel discussion where we ask the panel some preset questions, and then we'll open up more widely to you all. So please do use the Q&A function in the bar at the bottom, and we will try our best to get to you as soon as we can. If we can't answer your question during the session for whatever reason, we will definitely get back to you afterwards, and this recording will be made available online. So who do we have today? We've got a brilliant bunch. We've got Vicki from GDI Hub. She's our CEO. Frey Sagers from the Clinton Health Access Initiative. Aisha, who is a person with a lived experience. Dr. Chris Lavy, a surgeon and medical advisor for Miracle Feet, and is the co-founder of the Global Clubfoot Initiative. Ayesha de Costa from WHO, who focuses on congenital birth defects at the Department of Maternal, Newborn, Child and Adolescent Health. And we've got Louise from the Assistive Technology team at WHO as well. This whole discussion here today, this webinar happened because our colleagues over at CHI, the Clinton Health Access Initiative, were writing a report on prosthesis, which was published, I think, last year. And as part of that work, they found a lot of evidence related to Clubfoot. So actually this report wasn't supposed to be written, but it has been because of all the information that we gathered, or they gathered. We are so excited to have you all here today, and Frey is going to give us a rundown of the report and give us all some information on Clubfoot. So Frey, over to you.
Fantastic, and thank you, Catherine. Thanks, Global Disability Innovation Hub, for organizing today's event. Thank you also all speakers, panelists, and obviously everyone listening in here today, and thanks for joining. And one more thank you is to the colleagues from the Global Clubfoot Initiative who kindly shared a few materials with me that I am presenting now. To just give you a brief introduction about Clubfoot. So Clubfoot is one of the most common congenital conditions affecting 1 in 800 birds. And I know you're all doing the math now to just figure that out, but I'll help you a bit. That is equivalent to approximately 175,000 birds every year, of which the vast majority, 90% of cases, are found in low and middle income countries. Now, the cause of Clubfoot is unknown, but the effects are resulting in as you can see on the images, one or both ankles to be pointing downward and turning inward. And if left untreated, this can lead to lifelong impairment, affecting an individual's ability to stand and walk, and impacting opportunities for participation in society, education, and employment. And in high-income settings, impairment related to clubfoot is extremely rare in younger patients, due to the fact that most people have access to, or universal access to, appropriate, safe, and effective treatment. But unfortunately, in low and middle income countries, access to clubfoot treatment is rare, being less than 1 in every 5 children treated. Now, how can clubfoot be treated? That's what we're going to discuss in the next slide. So, Catherine, please feel free to take us to the next one. Thank you. So multiple treatment protocols have been studied, and the Ponseti method is now considered the gold standard treatment that is followed from birth all the way to the age of 4 or 5 years of age. And the method, as shown here in display from left to right, the method is minimally invasive and combines a series of different interventions, including casting, bracing, and a minor surgical procedure. The method itself, Ponseti method, was actually developed a long time ago in the 50s, but it was only popularized recently in the 90s. When it's initiated in the first weeks of life and followed compliantly, the Ponseti method is effective in resolving clubfoot in more than 95% of cases. Now, the benefits of treating clubfoot are obviously significant, and also from a financial perspective, the economic gains largely outweigh the costs. And when you're reflecting about what does it cost actually to treat clubfoot, the cost of supporting treatment for one child is estimated to be $500. So if you're just reflecting on that, that is a fraction in comparison to the estimated gains over the course of a child's life due to the increased productivity. Now, reflecting on this huge number of people that are born with clubfoot every year, the fact that treatment exists, the fact that treatment is in itself, the supportive treatment only costs $500, then why is treatment so low? Why are still so few children being treated? Next slide, please. So, as the Clinton Health Access Initiative, or CHI, we've been working, as Catherine mentioned during the introduction, under the 80-20-30 program, which I hope you all know, funded by our colleagues from UK Aid, from the UK government, and led by the Global Disability Innovation Hub, to look at market shortcomings and underlying root causes for a number of assistive products. And they're mentioned here on this slide, including a few mobility products such as wheelchairs and prostheses. And essentially, the goal of those narratives is to help identify opportunities to test new approaches and summarize, develop a synthesis on what needs to happen to overcome some of these challenges in increasing access. The reports that we've published are available on the 80-20-30 website, and I encourage you, if you're interested, to look into that. But building on the work that we had done in the field of mobility, data and information on clubfoot was gathered. And together with our colleagues from GDI Hub, we were in agreement that it was relevant to also develop a report to document these findings and to conduct a few additional interviews to make sure that we have a comprehensive picture of what is going on in the sector across low and middle income countries. Next slide, please. And I'm also crediting here the colleagues from the Global Clubfoot Initiative. What do the data tell us? Well, the data tell us that there's progress, as you can see on the slide here on the right. As you have heard from the introduction, the progress actually aligns with the time when the Ponseti method has been popularized. And also important to note that what we found was actually a high degree of coordination, collaboration, and data sharing, which is happening among the different implementing partners in the area of Clubfoot, contributing to this picture that we have today. So there is a lot of effort and coordination happening, with a very important role, obviously, of the Global Clubfoot Initiative, promoting and stimulating those efforts. And that's what we've been drawing on heavily when also we made that report. Next slide, please. Now, what did we find? And I'll keep it a very high level. I'll try to provide a quick summary because I could go on for an afternoon. But to draw your attention to a few key barriers to making Clubfoot services more broadly available across low and middle income countries. Firstly, awareness. Awareness is low, not just on the part of the parents, on the part of the healthcare providers, but also on the part of policymakers. And it's low on the fact that Clubfoot can be treated, on the benefits of the treatment, and on the service delivery pathway. So really, awareness is a major barrier that we will need to address at multiple levels. Second, when we had one of the consultations with global partners, there's a sentence that I really remembered. And someone was speaking about Clubfoot is in no man's land. And why that sounds perhaps a bit harsh, it speaks to the need for proper coordination and leadership between different departments involved within the Ministry of Health to ensure that children with Clubfoot are getting into treatment and that treatment is happening all the way through. And often that coordination is not happening and the leadership is not well established. So it needs to be clear to governments where the leadership should be, or there's a need for better leadership, stronger leadership within ministries of health to be driving the effort and scaling of this service. The same is also true when we look at the donor landscape. What we've found is that at least global donors in the area of neonatal and child health have not yet prioritized congenital birth conditions such as Clubfoot. And obviously, when that would happen, it would increase the ability to support any ongoing efforts and scale up ongoing efforts to reach more people around the world. Third, in contrast to high income settings, treatment is not embedded in primary and tertiary health services. I think it speaks a little bit to the two barriers that I explained earlier. And a lack of skilled personnel or personnel that is skilled in providing Clubfoot management poses a barrier to increasing treatment coverage. We believe that a systematic process of increasing the number of health workers skilled in the management Clubfoot is urgently needed. Fourth barrier, evidence-based global treatment guidelines could be developed, and they could be developed to improve the quality, the consistency, and a broader adoption of the services. Fifth, because it is essential that treatment gets completed over a prolonged period of time, there's a need for a reliable supply of quality and affordable braces and other consumables. They need to be accessible all the way through the treatment course. And lastly, a successful treatment outcome primarily depends on the ability of treatment adherence to a long-term treatment process. And when that doesn't happen, relapse after initial or incomplete rehabilitation may still occur. So this is just to point out a few barriers that we've observed as we looked into the data and spoke with the stakeholders. Next slide, please. Now, what does that tell us in terms of the direction we can go? What we believe is that in order to increase access to treatment, we really need a multifaceted approach with interventions that are happening both at the global and at the country level. And the following actions are recommended in the report, and we've tried to categorize these in line with the 5P framework that you might be familiar with through the GATE initiative. So the first one is on the policy side. We recommend to advocate to global and national actors, ministries of health and donors, for the integration and mainstreaming of Clubfoot treatment as an essential child health service, number one. Second, we recommend to develop global guidance and standards on the delivery of Clubfoot treatment services. Third, in line with the prior points, integration of treatment into government-led child health policies, plans, and training curricula for health workers. So there is systematic training and capacity building within the health system. Fourth, ensuring an adequate supply of all treatment materials, including affordable and quality food abduction braces. And fifth, test, validate, and adopt new solutions that promote a patient-centered care to improve adherence in low resource settings. So perhaps this sounds a bit, may all sound a bit conceptual. If you have not yet read the report, I would warmly encourage you to do so. And I think by reading more into the subject, it will become clear as to why these recommendations are made. But also over the course of today's webinar and today's discussion, I'm hoping that it will become clear to everyone here listening in what that means and what the path to successfully scaling access to Clubfoot services looks like. Thank you. Over to you, Catherine.
Thank you. An amazing presentation. It was a brilliant report, and you've really well given us the overview. So it's really powerful to hear it all explained like that. But without further ado, I will introduce you to our next speaker, Aisha. She is going to be talking to you a little bit today about her lived experience of Clubfoot. She has an absolutely amazing story, originally from Senegal, traveled to the US as a teenager and actually managed to achieve getting some surgery to help treat her Clubfoot. She's now back in Senegal, being amazing at a black belt in karate, so nothing has stopped her. Aisha, I just wanted, do you have any words to say before I play your video, or shall I just fire away?
Yes, you can fire away, but I just wanted to thank everyone for being here and having this much needed discussion. And I think it'll be much easier to answer any questions once you guys have a chance to look at the video first and get a broader understanding of the person I am.
Amazing. I'm so excited to show everybody this video. So this is Aisha. Please do let me know if you can't hear the video.
My name is Ayesha Tumbalo, and I am almost 41 years old. I was born with bilateral club feet in Senegal, and I grew up walking with my feet for the first 16 years of my life until I had the opportunity to go to the US and have surgeries. When I was first born, they noticed that my feet were completely backward. But unfortunately, being in Senegal, West Africa, a country with limited medical access, there was really nothing that was said to initiate some kind of treatment process. So my parents tried, I think they felt guilty. They tried to do everything they could to change my life, to give me a better opportunity to have treatment so that I would be more accepted in society. I mean, today there are things like Pansori methods or casting, but I think that knowledge and access wasn't available back then. And so that motivated me to look for other options. And back in the 90s, there were no internet. And being that I had the opportunity, again, that was different from most children, I went to school. So my parents educated me and they treated me just like my other siblings, there were no other children that had club feet or any other form of disability around my school. So I became very studious and a teacher's pet. And when I heard about opportunities of other NGOs coming to Senegal or my little hometown of Sébikotane to sponsor children to help them with education and perhaps medical needs, I said, I need medical need. I have medical condition. I need help. So basically volunteered myself, and I understood that for any change to happen to my feet, it would have to be outside of Senegal. And so it became my mission to find a sponsor through these programs, through these NGOs. And that's when I found a sponsor. I had a match in the US, and that's where I got connected with my Costa family. And that was all just through pushing and I thinking about it, I'm like, I'm not sure how I did it, but I knew it was an action that I had to take myself in order for something to happen. My first arrival in the US, my initial thought, first of all, was because I went from Senegal in December, never seen snow or winter. I arrived in Minnesota. The shocking part was the intensity of the cold to my feet, because I could not wear shoes that basically protected me from the snow. So that was a challenge immediately. So yeah, I think I went numb immediately from the snow and just everything else. Immediately, I had to transition from being a child into an adult that's making decisions hand in hand with my legal guardians. And initially for me, it was more like my dream is becoming true. This is a miracle. And I didn't have any expectations that I could visualize, because I didn't know what the process would entail. So I was just like, I'm excited, I'm here, this is happening. Let's wait and see what's gonna happen. My experience for Senegalese healthcare was different. I would say, I don't want to use the word non-existent, but it was limited and challenging. Many people are sometimes struggling just to put food on the table. And we have a healthcare system where if you don't have money, you're left out. And I think that's completely unfair. And that explains the reason why we have so many people out on the streets crawling and unable to even think about going to a hospital. You know, people always say the United States doesn't have national health care, but at the same time, there is health care available when you seek it. And people generally know about it because it's information sharing. People talk about it, they share, it's an advertisement. So even if you don't have money, the poorest person in the US has access to health care. There are lots of challenges that exist for children with club feet or any other disabilities here in Senegal, especially. I recently come back to Senegal about a year ago, and just walking around the streets and just looking around from what I see. One, there is the mobility challenge, because I've only seen thus far one child who reminded me of my old self, had both feet turned around, probably around age 12, and was walking with them. And I just immediately say, that's me. And I recognized myself in him. And suddenly I felt empathetic. It's like sad, like this child thinks there's no hope. He's never going to change. There's nothing that's ever going to be to change his feet. And they learn to accept that, I think, very early on. And I think that's what hurts me a lot. I'm not gonna get emotional, is my situation was different because I wanted something done. The other challenge that children face, whether with club feet or disability, is stigma and acceptance in society. So having a family that has a child with club feet and them knowing nothing's gonna happen to them immediately is, this child is not gonna become something productive, like a productive member of society. So most of the time they become a street child, you know, kicked out of the house, or they're hidden But until we all accept people with physical disability are human beings, it's just their feet look different, or maybe they walk a little differently. So we need to treat them just like everyone else. Because when you are out there and everybody's looking at you, judging you, and thinking of you less than a human being, it makes you crawl back into that hole. And then the hope that you have no future. You cannot become, a director. You cannot become a president, or you can't become, an astronaut. That's not okay. And I think we need to change that. I'm wanting, leaders and the world to just see and understand is, next time you go out and you see someone walking with crutches or in a wheelchair, just say, hello, how are you? How is your day? When we do that as adults, the little children see that and they imitate it. I would say that today I am the person that I am because of Clubfoot. It's made me more aware of my environment and people around me. It's also given me the opportunity to realize and accept that my situation is completely different than probably 100% of other children, because not everyone has that chance that I did. To be extracted out of Africa and go to another country that has a completely different healthcare system and receive treatment. But to see children today who have this disability, that's so painful to watch, because with the exception of someone who was actually walking, the majority are crawling on their knees. They are using maybe one crutch, but just the fact that they have no hope, the realization that something can be done to change it is just so limited and non-existent. That has to change. This is 2021. And I think overall, we can start slowly in making that change.
Isn't that an amazing video? Thank you so much, Aisha, for your contribution. Do you have 1 or 2 minutes left? So is there anything that you'd like to add to tell people about? What do you want people to take away from your story?
Yes, thank you again for having me. And I'm sure many may have questions after watching that video. One thing that I mentioned in the video is that my Clubfoot never really stopped me. As you can see it, I've never seen myself as someone with a disability, and it's society and our environment that imposes that on us. And I never want people to look at me as someone to be to feel sad about, but rather to see a strong individual who, despite the challenges that they are faced with because of society, governments, institutions not acknowledging what that person is living with, there's always hope. And reach for the stars and just keep fighting like I did. And I want every child, every individual who feels like they're limited to know that there are people like me out there looking out for them. And hopefully one day soon, we will make life a lot more easier for them.
Amazing. Thank you so much. And we will come back to you during the panel session, which is on the way. But next up is Vicki Austin to talk to us a little bit about assistive technology in general and to hear some of her reflections so far. I'm going to see if I can stop sharing my screen so that you can see her. Just 1 second.
Thank you so much, Catherine. And Aisha, thank you for sharing your story, which was a really powerful one. And I think it's a kind of a nice place to start, really, in terms of thinking about what's possible here. I wonder if everyone can see me and hear me. Just give me a shout if you can, because I can only see my face on a slide. You can hear me, right?
I see you, but I'm trying to stop sharing, which is
no problem. So let me start by first of all saying thank you very much for letting me speak at this event. This event was kind of not supposed to happen. Like the Clubfoot product narrative was kind of not supposed to happen. It wasn't one of the things we were contracted to deliver. It wasn't one of the things we worked with Chai to scope out. it came to us because the data was emerging from the amazing work of the organisations that have been plugging away in this sector for a long time, many of whom you will hear from today, and our gratitude goes to all of those organisations for supporting the work today. I think GDI Hub, for those of you that don't know us, is a research and practice centre that grew out of the London 2012 Paralympic Games. We are currently working with about 70 partners in more than 35 countries on a programme of about £50 million addressing access to assistive technology. And so far, we've reached 21 million people. We're also the global collaborating centre for assistive technology for the World Health Organization based at UCL, and we use research and teaching and innovation programs to test what works, and we advocate for change. And I suppose I say all of that because that brings me back to the proposition that we have before us today. What GDI Hub is seeking to do is to address real change in the world. They're bringing forward the research and the evidence that we've been able to gather as a team in order to effect real change. And that's something which I think Freya set out really well for us. We have the opportunity here to influence the lives of 175,000 people per year, 90% of whom live in low middle income countries, who are not just experiencing impairment, but also the disability that results from challenges associated with impairment, also pain, also cost, as we've heard, and also lost income. And if you look at the AT scale report that was recently produced, that income could be as much as $100,000 per family who don't have access to the assistive technology they need in order to access school or work. And so really the universal access to the treatment for Clubfoot, which we heard is prevalent in the global north and is only received by 1 in 5 people in the global south, is something that we can address. And so I want you to believe really that this is an issue which we can solve for, that we want to solve for it globally, and that we should do this soon because progress, as Frey showed on his graph, has been far too slow. And we're at a really poignant moment in the history of addressing issues associated with Clubfoot, because we have the technologies in place now and we have a lot of learning from their application. And so it's an opportunity that we have really to build on what we've learned so far and really kind of take the next step to forward change. And so I was reflecting on what we know, what we've learned so far from the perspective of 80-20-30, the programme, which you'll know GDI leads, but also where we came from. So we came from London 2012 and the Paralympic programme that worked there. And the things that I've learned are we need leadership with a common mission. We need a partnership where everybody knows what their role is in the process so that everyone can contribute for change. Because we can't do it by ourselves. If we could, one of us would have already achieved this, right? So we need to work together. We need tools and guidance and data, and we need investment, but it's more than cash. It's also resources and resourcefulness that we need. And so thinking about what we've learned on the 80-20-30 project so far, it seems like in the space of Clubfoot, we have a lot of data. So 80-20-30 has returned about 62 peer-reviewed papers so far. And we have the product narrative. We've set out what we need to do in this space. We also know that innovation is necessary. And actually, we're really privileged to have invested in Miracle Feet in Nigeria to address some of the innovation in bringing some of these products to market. We know that community-led solutions are important. So anyone who works in design or technology will tell you to put users at the forefront of designing solutions, whether they're products or policies or interventions. And we know systems change is necessary. So whether that's fiscal change around the way that products are brought to market, whether that's tools or support to national governments to embed change, we know that we need to bring forward all of these solutions together. And so what? We can sit here and we can talk to each other about how important it is. But I think there's one thing that's really clear, and that's we need some global guidance on Clubfoot. We need a strategy for coordinating action. And I hope that I speak alongside my colleagues from the WHO, who I can't wait to hear from, in saying that WHO has an amazing role to play in leading us as we move forward. It's the case not just in terms of Clubfoot, but in terms of many assistive technologies, that there's a silo of applications. So in this case, we're looking at teams working on maternal health, as well as teams working on AT, both products and services. And it's our job really to find a way to make it work in the middle of all of those silos. We call it the magic in the middle. And it seems to me that Clubfoot is a prime opportunity as we are looking towards the World Report on Assistive Technology next year, a big summit in Norway in February, thinking about disability and development, and really driving forward what tools we can produce at a global level that can support governments in procuring the products that are necessary and implementing the services within the context of universal health coverage that we need in this space. So I kind of put it to you, panelists, and all of us really, that this is an opportunity to really see impact in the AT space by driving forward what we need to deliver on Clubfoot, by making that global guidance and that global coordination a reality. And by really using the example of Clubfoot as an exemplar of how we achieve impact in the assistive technology space. And I guess for all of us, we will come to see our learning and our, no doubt, failures as well as successes along the way as a real opportunity to make sure that we are addressing the needs of the 900 million people that are currently living without the assistive technology they need, and making Clubfoot a real priority in that space. And so thank you again to everyone that's participated today, and I look forward to the discussion.
Amazing. Thanks so much, Vicky. I am now going to ask all of our panelists to turn their videos on, please, because I've got a few questions for you. So after all of that, we are now going to put some questions to the panel and see what some of their responses are. So I wondered, first of all, whether you guys could introduce yourself. I know I introduced you at the beginning, but it'd be great to hear you describe who you are in your own words. So I'm going to pick Chris first because he's top of my list. So go ahead. Oh, I can't hear you.
Sorry about that. Yeah, you're also top of my list. I'm a surgeon working here in Oxford, and I got very interested in Clubfoot when I worked in Africa and lived and worked in Malawi for 10 years. And I think I have to apologize to everyone that I have operated on hundreds of people with clubfoot children with clubfoot before I knew of the Ponseti technique. And then when it came out, it absolutely revolutionized my life. And I've now become a pusher of the Ponseti technique. So I'm one of the founders of Global Clubfoot Initiative, which I'm sure you'll hear a little bit more about later on, and a medical advisor to Miracle Feet.
Brilliant, thank you. Louise, you're next on my list.
Hi everyone, my name is Louise Puli and I am an orthotist and prosthetist by background, but now I'm working with the Access to Assistive Technology team at the World Health Organization, and I'm looking forward to answering some of your questions today. Thanks.
And Ayesha de Costa.
Hi, my name is Aisha de Costa. I'm a physician as well, and I work at the Maternal, Newborn and Child Health Department at WHO headquarters in Geneva. And I work with congenital defects in helping countries support the programs to improve the detection and management of congenital defects.
Brilliant, thanks so much. Our other three panelists are Aisha and Vicky and Freya. We've already had introductions from them, so let's fire away with some questions for you. We saw at the very beginning when Freya did his presentation that the number of children enrolled each year for the Ponseti treatment from plaster to brace has increased from almost zero to over 30,000 each year at the moment. I put this question to everybody, but what do you see as the next steps to scale up that progress in the next decade, so that we can try and prevent this impairment for 4 in 5 children who currently don't get treatment? Any takers?
Yes, sure, absolutely. I think efforts to increase access to assistive technology through multiple approaches will see the number of children with access to the clubfoot braces they need continue to increase, and probably faster than the previous decades. To give you some examples of things that WHO is doing to contribute to this, Clubfoot braces feature on the WHO Priority Assistive Products list, and this contributes to raising awareness about how important these products are. Further to this, WHO has also recently released assistive product specifications for clubfoot braces. And these specifications aim to ensure that the people that access these products are accessing safe products that meet minimum product standards. Apart from these, WHO alongside UNICEF has also recently released an assistive product procurement manual. And this aims to increase countries' capacity to procure the priority assistive products. All in all, I feel like we have some great momentum at the moment. So I have no doubt that access to assistive products for Clubfoot will continue to increase. Thanks.
Chris.
Yes, you can see I'm dying to speak. What can improve things? Well, firstly, improved awareness of Clubfoot. I had to confess I am an orthopedic surgeon, but I had seen very few club feet in my training, and many people who I meet all around the world don't really know much about Clubfoot. So we've got to really increase awareness, and I think it should be on the curriculum of every healthcare group. I mean, every healthcare cadre around the world learns about malaria and diarrhea, and they should learn about Clubfoot, even if it's not going to be their specialist area, so that they're really aware of what it is and what can be done. I loved the way that Vicky said that we've really got to move forward with policy, and it'd be great to involve the WHO and actually get guidelines really clearly written down on treatment of Clubfoot. Clubfoot's it's an interesting area because the treatment has developed so much in the last 20 years, and it's been driven by NGOs, but NGOs can't take it forward. It's got to be a combination of NGOs working with governments and working with ministries of health. And I think it's an exciting area to develop policy. I mean, you could say, ideally, it would have been something that's been started by ministries of health, but it wasn't. It was started with the NGOs. But so many aspects of healthcare, even in our country, started with NGOs. I mean, things like palliative care, things like Mackinnon cancer care. And we have to work out ways of working with ministries of health. I don't want to speak all day, but I'll just say one more. And we've got to continue with research and dissemination of research, and the great work that Miracle Feet has done on actually looking at the massive economic benefit of treating a clubfoot. You know, if you told me I could get 200% return, 200 times return on an investment, I'd do it tomorrow, and that's why I'd love to spend my money supporting clubfoot treatment. Thank you.
Thanks, Chris. That was amazing. I can see Ayesha's got her hand up.
Yeah. So thanks everyone for inviting us to this seminar. It's been amazing to listen to the passion that drives all of you working in this area of clubfooting, and I feel very grateful to be part of this group here today. But what I'd like to pick up from the WHO perspective is I just like to pick up where Aisha, my namesake, left off, which is where she said that, you know, this child whom she saw felt that nothing is going to change. And I think this is part of the problem, because there's this myth, I'm talking not just about clubfoot, but about congenital defects as a whole, that nothing is going to change. This is a problem that, you know, you only treat in high income countries, you go to XYZ countries to sort it out. And that's something that we really need to change. And that is our focus now in the WHO, to taking not just clubfoot forward, but seeing clubfoot as part of the big umbrella of congenital birth defects. We've had to focus, and perhaps rightly so, on the more immediate causes of neonatal mortality and child death in the past decades. But we've come to a stage where we are clear that a lot of the burden of congenital defects is actually born in low middle income countries, where this myth of, you know, this is a problem that they can treat in high income countries still persists and is very pervading. So I think from the WHO point of view, what we are looking to do in the next biennium, in the next 2 years, is actually to think of moving congenital defects as an agenda forward and trying to provide some kind of guidance to countries on how not just screening and detection, but what you do after screening and detection, putting in place systems for management, which are not so easy because, like you all said, this is something that requires long-term follow-up. It requires some specialist centers. It requires training. So what are models that can be used in different countries depending on the health system that there is? Where is a public-private model? Like Chris just said, there's a lot, there are a lot of NGOs on the ground. In some cases, there is a strong public health system where a public health system that is reasonably strong to pick up certain kinds of management of congenital defects as a start. So we have, and you may have a central hospital in the city with follow-ups somewhere down at lower levels. It just depends on the complexity of the disorder and the kind of follow-up that we're talking about. In other countries, you may have a very strong private sector through mission hospitals, NGOs, in which case you want to have collaborations between the public and the expertise in the private sector, or I should say the non-governmental sector with the public sector. So there are different models that we want to try, but for sure, one of the big things that we plan in the next biennium with the WHO in child health is really to move congenital defects, the detection and management, onto the agenda, particularly for low-income country settings, because this has somehow been viewed as some sort of an esoteric problem in the high-income world. But we want to sort of move that view a little bit. And I think one of the ways to do it is our focus has so far been very focused on mortality issues, mortality around us, and we need to really shift gear to look at the morbidity. How much are these children are sort of in the background. We're not seeing the cost of their management, the cost that the loss of potential that there is to societies in low middle income countries. So I think we also need to shift the needle to talk about the morbidity burdens that countries are facing to drive home the point that it's so important to actually start the treatment and management of these children. Not just for Clubfoot, but I'm talking more about congenital defects as an umbrella. Over.
Thank you so much. And actually, I have to apologise because I was going to invite my colleague Anne to give her reflections, but actually it was a good thing because my next question is actually to do with policy. So my next question is, what do we require to advance the development of supportive policy and what opportunities may exist to do this? So I invite Anne to give us her reflections both on the reports but also on that question, if she's got any thoughts too. Hi, Anne.
Hi, good afternoon. So I guess reflections on this session. Well, first of all, I'd just like to thank all the speakers. I think it's been a really informative session. And it's been great to hear from Aisha just on how it felt from a really personal point of view. How, even in return to Senegal, she couldn't see any, any way that things have changed and that she really had to push herself to make things happen. And obviously we want to change that. And I think, as Chris said, really raise awareness of, the fact that there is treatment. We do need to maybe sort of test and research the treatment and some of the, braces. And I know that there's a range of options available in the market. So there is work to do still. But I do think that, for one, we know about Clubfoot. We know that there is a kind of a treatment available to treat it. We know it works. We need to spread the word. And I think, you mentioned policy change there. It is really hard, Catherine, but I think that's where the data, that's where the research comes in. Let's, and I think the project narrative's a really good start for that. Let's pull together the data. Let's figure out, what the return on investment is. Let's really raise it up the agenda. I think, as both Aisha and Louise said, we can do a lot from government on this. But it is a lot of the time it is the NGOs who really drive government to make a difference. So I think we need to work together. And was it Bray or Vicky might have said earlier, you know, this is where we really need to pull together, whether it's government departments, whether it's NGOs, we really need to coordinate what we're doing. We need to prioritise, raise it up the agenda, and you know, we can really make a difference.
Thanks, Anne. And I have to say, all of this work is thanks to Anne and other members of our FCDO team as well. Obviously, these product narratives were all put together with UK aid funding, so we're very appreciative for that. I've also spotted Kirsten Lenst on the call, so I'm going to go to her because she's at USAID. So I'm just wondering if she's got any comments as well. Hi, Kirsten.
Hi, everyone. Thank you. Good morning, good evening, good afternoon. I'm always happy to provide a few words. As anyone who knows me, I'm like Frey, I could talk all day. I really want to sort of look at this aspect of how we think about Clubfoot on the global health agenda, thinking about securing support from donors and policymakers. And I just had a few sort of thoughts. So when we are thinking about opportunities to integrate and align Clubfoot on the global health agenda, I think starting with a broader framework from both a physical rehabilitation as well as the newborn and child health and well-being perspectives are crucial. And especially, as Aisha sort of pointed out, that if we look beyond those more traditional mortality and morbidity indicators and really start considering function as an indicator for health and well-being. Since I'm the senior advisor for rehabilitation at USAID, of course, I'm going to have always a little bit of a rehab perspective. And I think that Clubfoot, from a physical rehabilitation perspective, Clubfoot services need to be included in the framework of strengthening quality, sustainable physical rehabilitation services in health systems. We know that 2.4 billion people would benefit from rehabilitation services to optimize functioning, and that these essential services should be comprehensive, inclusive, and accessible to any person. I think that if you present Clubfoot services as a unique agenda item, you could actually potentially limit interest. But if Clubfoot services are orientated as an essential service that should be available in a comprehensive health service, especially since there's an available and efficient, effective intervention, that there's potential risk to spark interest, and really going down to that level of talking with ministries of health to spark their interest, to drive that agenda a little bit. I also think that it is key to develop globally recognized strategies and standards and guidelines in order to provide not only guidance, but also as indicator benchmarks for intervention protocols and quality, as well as to provide data for evidence-based decision-making, especially for policymakers that can elevate that discussion and also provide potential opportunities. I also think that there are opportunities to elevate this conversation from a maternal, newborn, child, and adolescent health and well-being perspective. But again, not as a standalone issue, as Aisha was pointing out, but as a component of the comprehensive essential services across different healthcare levels, from community to tertiary, that include training for early identification, intervention, referral for better health and development outcomes. And lastly, my sort of thoughts here, one, just congratulations. We've all heard the story of how this sort of organically grew, and that in itself, I think, is a testimony to how important this subject is. And to work on this study, especially because of the learning. You know, Frey, I think in some of your very first comments that you made was you commented on the return of investment. These are sort of key elements, I think, that we really need to be able to drive some of this conversation. When we hear that, when ministries of health hear that, you can invest X dollars and receive this much in return, that's a really substantial argument for investing in these services. So I think that those sort of learnings are really key, especially coming out of this study and the report. And to think about other tools and discussions like we're having today, because these are really key and really teasing out the opportunities to craft some of those best approaches to move this agenda forward. So from my perspective, those are my few words. And again, thank you very much for letting me join this morning, but really having that broad perspective of how we really include it in essential health services, no matter where they are on that continuum, I think is really something that we need to do and is really key. Thanks for letting me pop in for a moment.
That's perfect. Thank you. And thank you to you both for that. I think there are a couple of things that I wanted to raise as well, and questions that I wanted to ask, particularly around the process of treatment. So I know we've talked a little bit today about the casting part of treatment, and then going on and using the brace. One of the biggest questions that came out of the report, and something that, you know, Frey mentioned earlier, was adherence to the use of the brace. And that without that, unfortunately, you know, relapse, the chance of relapse is increased. So I'm interested to get a varied perspective on this, both from you, Aisha, from your lived experience perspective, and what you know from your on the ground experiences, but also, you know, other experiences from the panel. How do we increase adherence to the brace? How do we make sure that we really, children can receive the full impact of that?
Thank you for that question. I think, for example, having listened to my story, we can see the difference if we start early on with the children, with the casting and the bracing, because having the example of the lived experience, someone who had never received treatment and waited 16 years to get treatment, something I realized reading back through my medical records was that there was change within 3 weeks of just casting. I think I mentioned something that I started with casting that was being changed weekly, and on my right foot, which was quite challenging, they were able to see change after 3 weeks of weekly cast change. And I was like, oh my goodness, had this been done very early on, so much could have been changed. Obviously, my life would have transitioned completely differently. But when you think about the financial impact on that, it's a miracle and great that the procedures were not costly, thank goodness, because of the institution that provided them. However, imagine this was something that we had to pay for surgeries. After 7 surgeries, that would be a lot. And financially, it makes more sense to start. So how do we make sure this happens? And since we are working in lower to middle income countries, I think getting the message across, there's been a lot of conversation about, you know, policies and what do we do in research. But I think, again, from a different perspective as an African, and I know how people receive information here. It is lacking, number one. And how do we make sure that that information gets to the right person? How do we make sure that the family with the child with Clubfoot or any other form of disability has access to that information, knows where to go and what to do? And in terms of making sure that we are doing everything that we can for them to stay within the course of treatment, which is after casting, sticking with the bracing so that we can prevent relapse. Again, is education and communication with that family, with that parent. And also keeping in mind that we are working with individuals that may not be as educated as the rest of the world. And they have this, again, this is from personal experience, that I am going to a health entity and it is up to them to tell me what to do and just explain everything to me. So they're a little bit on the outside. So if we don't communicate the message directly to the parent and tell them the hard truth, if you don't follow through with this, this is where we're going to end up, and just say it as it is. And I think that's how we can probably make the biggest impact and make sure that all the work that is being put forth, research, investment, and everything, flourishes as we go along. Thank you.
Thank you. Chris, you popped your hand up there.
Yeah, like all the other speakers here, I just want to talk the whole time. It's really crucial that the braces are worn. And for those of you who haven't been involved in treatment of clubfoot, there's two components of it. The first 6 weeks, where you watch your child's foot turn from severely deformed to absolutely looking normal, and parents are so delighted. But somehow we have to sit with the parents and say, this is part one. For the next few years, your child is going to need to wear a brace, and that's really, really hard. So how can we help the parents and the child? Well, certainly continued research on braces, making them more comfortable, making them look beautiful so that people want to wear them. And then supporting the parents, having a phone number that they can ring if there's issues, and having counsellors or parent guidance who sit with them and encourage them through it. And some of the best helpers and encouragers are the parents who've been through it all, who'll just say, you know, stick with it.
Thank you. I saw Vicky had her hand up before. Is it still up or no? Louise. Oh, I can't hear you. Yeah. Yeah, we can hear you now. Oh.
You can hear me?
Yeah, I can hear you now.
Oh, great. It still says I'm muted, so I'm not sure what's happening. I think anyone who's worked with clients and families of people living with clubfoot know that compliance is really an ongoing journey together, and the relationship between the health worker and the family and the client's really, really important. At WHO, we have a 4-step product provision, which we believe really supports good compliance and supports the ability for users of assistive products to get the best treatment possible. These 4 steps include the selection and appropriate fitting of the correct product. So if you select the wrong size orthosis or a brace that's not suitable, you can't expect the user to be compliant. The product needs to fit. So as previous panelists have spoken about, when children grow, they need to come back and have those orthoses replaced really regularly. The 3rd step being user training, and that communication with the family about the importance, the education of what will happen if the orthosis is not worn, the extremely high rates of relapse in clubfoot. And finally, appropriate follow-up. So in my clinical experience, there are many clients that will come back weeks and weeks after their brace or their orthosis has stopped fitting, only to find out that they end up back in plaster once again, which can be really, really frustrating when you feel like, as Chris mentioned, you finish that journey with plaster, but then you end up back there because of non-compliance with the orthoses. So I think supporting those 4 steps to all be in place and all be really, really strong supports ongoing compliance and better outcomes.
I'm going to go to the next question because we're rapidly running out of time, but I really wanted to circle back actually. My last question to you before I open to Q&A is what opportunities exist to better integrate and align clubfoot in global health agendas to secure greater levels of support from donors and policymakers. And I also wanted to kind of also tack on another little question there, which is a bit cheeky of me, based on Aisha at the WHO's comments earlier in the need for sort of more information and more research and sort of pulling together. What is it that we as a movement can do to help support progress on some of these issues? Is it a matter of research, or I don't know? I'm looking to see whether there's an opportunity there for us to better support with this. So I open that up to everyone. Any takers? I think I'll
let someone else speak first.
Chris, go for it, and then I'll go to Vicky.
Okay, yes. I think those of us who deal with physical impairments have been slow to come to the table of developing government guidelines and developing National Health Service plans. just to take a step back, when I was involved in the Lancet Commission on Global Surgery, we looked at every country in the world's 5-year healthcare plan, and none of them mentioned surgery or anesthesia. And why was that? It was because they weren't at the table. The people who came to the table were the people interested in maternal health, HIV, malaria, TB. And of course, those are really important things. And I think we've got to go to the table. We've got to go to the policymakers' table, and probably via the route of WHO, with the great story that we have.
Thank you. Vicky.
I love this session. This is a really great opportunity. I mean, what do we need? We need advocates like Ayesha. We need pushers like Chris at the table. We need clinicians turned policymakers like Aisha and Louise, who are making big change. We need visionary donors like Anne and Kirsten. We need renegade implementers like sometimes us and sometimes Frey, and lots of other people too. And mostly we need the voice of people who are living with Clubfoot at the centre of all of it. We talked about awareness raising, policy guidelines, supporting government ministries of health, research, models of success, political will and investment. That's a lot. So I'm just kind of really curious as to if we can take one next step, we can do one thing together as people that are engaged in a conversation today. And I don't know if it's fair to look at my colleagues at WHO, but I might want to a little bit. What can we do that if the policy guidelines on the treatment of Clubfoot are the next first step? How do we make that reality? Or is it something else? But certainly from a GDI side, I'd love to throw our weight behind taking that next step.
Louise, is that an old hand or a new hand?
Oh, it's a very old hand. Sorry.
Don't worry, Aisha then.
Yeah. So thanks for that, Vicky. So we fully acknowledge and recognize the need to actually have WHO leadership in this area of congenital defects. I'm not talking specifically to Clubfoot. So our thinking for the moment is that our priority really is to push congenital defects, whether it's congenital cardiac defects or congenital hypothyroidism or hearing or Clubfoot, whatever it is, because different countries have different burdens in different places. But to put congenital defects on the agenda in low middle income countries is our #1 priority as far as this area of work goes. We're not thinking immediately in terms of guidelines for condition A, condition B, condition C. That's the next step. But the first step is to enable countries to prioritize this. And as Chris was saying, sometimes it means talking to MOHs about what is your 5-year plan and where does congenital defects fit into it. And if congenital defects fit into it, then which congenital defects? Because often, sometimes you're talking about conditions that are 1 in a million and the health ministry says, big deal, this is not something we want to invest in. So, it's often talking about the burden that's relevant to that context. What do we do? What do we need to have in place? If your burden is congenital hypothyroidism, then that's what you need to focus on. If you have a burden of Clubfoot, then that's what we need to focus on. So I think we aren't really, Vicky, to take your question on head on. We aren't really thinking of Clubfoot guidelines for any condition, whether it's condition A, B, or C at the moment. At the moment, our big push is to really move congenital defects onto the health agenda in the ministries of health in low-income settings. We want to come up with this. We are planning a consultation sometime next year, and I'm sure I'll reach out to some of you at that point in time to actually think of what are models in low-income country health systems to be able to embed this kind of care, detection and management for congenital defects, because they're increasingly becoming a bigger part of the child morbidity spectrum that we're concerned about, even in low-income settings. And I think one thing that is not said enough is that at 70 to 75% of birth defects can actually be treated or managed or improved in some sense. There's a sense of fatalism around birth defects, which I think is something that needs addressing as well.
Thank you. I actually think that Rosalind Owen from the Global Clubfoot Initiative has something that she'd like to add.
Hi, Catherine. This actually goes back to I messaged you when we were having the discussion on adherence to the bracing phase. But I think this comment is probably relevant to the whole discussion that, you know, over the years, we've learned so much about how to encourage adherence and how to implement this great work. And I think, you know, in answer to the question on adherence, but also Aisha's comments that, you know, we've learned so much about how to train, how to support families, how to implement throughout the whole treatment journey. And I think it's so great that we have a model to now offer to say, you know, we've learned so much, and I'm sure that it can be applicable to other conditions too.
Lovely, thank you. I'm going to very hurriedly move on to our Q&A because I know we've got lots and lots of questions for the panel here. So let me just pick one. Kate, I can't open it. Are you able to help me?
Hello, yes, I can help. So we've got a few questions that have come in. A lot of them have fed into the idea around the brace compliance and the discussions you've been having there. In terms of one for Aisha, there is a question that's come in about your lived experience, and you've been highlighting such an important issue around awareness. What channels and techniques do you think may be most effective to raise awareness that Clubfoot is treatable in Senegal? Oh, you're on mute, just to let you know as well.
There, better? I'm unmuted now.
Yeah.
Yeah, so I was going to say thank you for that question. One of the best ways to make sure that, you know, these awareness does get around to fast. Definitely working together with health ministries, the health system in Senegal, as well as Senegal. I can speak personally, being a country of faith, reaching out to the local leaders, because people do always go to them first for guidance before even going to the next step. So I understand that's not a conversation that's being touched on, but I think that's something that we really need to focus on. One of the things that I have seen is a lot of the times people experiencing such limitations, whether other forms of disabilities or Clubfoot, come from rural areas, not so much from the cities, and they are traveling long distance to the capital cities to seek treatment. But their first step is always going to their local leaders, whether that is a mosque or a chef de quartier, but making sure that we reach out to those individuals, that they are aware of access to treatments and the methods that are available, because they can actually communicate with the families in also implementing one of the questions I answered earlier, you know, making sure that we stay in adherence to the casting and bracing methods. So thank you.
Next question, Kate. Oh, you're on mute.
A few, Ros, I can see you're answering a question live, typing it there. I didn't know whether you wanted to answer that one live about the quality comfortable braces. And in terms of, do parents stop bracing because of the quality of the braces in these countries? Did you want to come on and answer that?
Yeah, sure, thank you. So what we find is there's a huge range of factors in why parents or families stop using the braces. One of them can be the quality of the brace, but more often than that, we find that having the time and the funds to attend frequent appointments, it often means taking a whole day off work, and if you're a daily wage labourer, that's really costly. Sometimes they would have to buy the braces. Sometimes it's more about education on why bracing is important. Sometimes you actually have to educate the whole family or the whole community about why bracing is important. Otherwise, mothers get asked, you know, why do you keep putting those braces on? The feet look fine. Why don't you just stop? And so there's a huge range of factors involved. Some really interesting research came out of Bangladesh, actually, I think it was last year, and they found that when clinicians have empathy with families, it really helps them keep going with the bracing. And I thought that was really interesting as well. Thank you.
I'm going to jump in and say we're actually at time. So we've got lots of other questions, but it's such a shame that it was the fastest hour and 15 minutes. So we've got some other questions in the chat. Please be rest assured that we are not going to ignore any of them. We will certainly answer all of those questions after this event today. In the last minute, I'm going to do a quick fire round, panelists. So get ready. I want to ask you, what's the one thing that you want people to take away from this conversation today? So I'm going to go in the order that you are in the screen. Louise, you're first.
Oh, just thank you and keep going, everyone. I think we've got some great momentum and obviously some really passionate and powerful groups on this call today and powerful attendees who want to take this and run with it. And I think if we do that, we're going to just see nothing but fantastic results for the global Clubfoot community.
Thank you. Chris, you're next.
Clubfoot can be treated, and every country has got the required level of staff to learn the treatment. So let's go.
Thank you. Frey.
I was thinking exactly the same. I want to say this is feasible and high impact.
Thank you. Who have I got next on my list? Vicky.
We can do hard things. We can do this. Let's meet in 6 months' time and see what progress everyone has made.
Fantastic. Aisha to Costa. I use your last names, there's two of you.
Yeah, my message is actually to see how can we get congenital defects on the priority burner in ministries of health in low-income country settings.
Thank you. And finally, lovely Aisha with her lived experience. What's your one thing you want people to take away today?
Okay. My message is that, as Vicky mentioned earlier, on this panel, we have all the right people to work together, from lived-in experts and all of our research teams and all the different NGO organizations put together. Now let's all work together, put our heads together and reach out to the missing links, whether that is, as I mentioned, local leaders, country leaders in each country that we attempt to work with, and make sure that our mission and message gets to every single individual, every child who is right now living with limited access to treatments or just to make their lives a little better. So thank you.
Thank you. I say a massive thank you to FCDO and USAID for coming today as well, and to all of you, particularly to Try as well for putting this report together in the beginning. And also just a little thing from me, which is that obviously 95% of children can achieve successful treatment, but there is that 5% that don't, and they need assistive technology too. So we haven't forgotten those either. There's just a long list of people that we need to change the world for, I guess. So this recording is going to be available afterwards. All the questions will be answered online. You will certainly see blogs and all of that coming. So do stay tuned, and thank you all very much for attending today. So thank you. Good night. Have a lovely evening. Till next time.